In this video, we're going to review everything you need to know, or most of the things you need to know for dental materials. So let's start with learning about impressions for study cast. So study cast is like study models, and then custom-made oral appliances. We, as hygienists, can make custom-made oral appliances, and we're going to look at what we can make. So some things that you might remember from dental materials is that you probably made a sports guard or a mouth guard. Sports guard, mouth guard are the same thing. These words are used interchangeably. You may have made a whitening tray. You also may have made a study model for your clients. So let's start with the question first. Which is a negative imprint of the teeth and surrounding tissues used to create a reproduction of the teeth and surrounding tissues? A die, a study model, dental impression, or diagnostic cast? Negative imprint. Not positive, but negative imprint. The answer is dental impression. So C, dental impression is a negative imprint of the teeth and surrounding tissues, and it is used to create an accurate or a 3D reproduction of the teeth and surrounding tissues. Everything else is a positive reproduction. So a die, which I'll show you a picture of, a study model, that's a positive reproduction. A cast is a positive reproduction, but dental impression, it's when you take an impression, it's a negative imprint because it's not the actual model, right? When you get the actual model or the die or the cast, that is considered a positive reproduction. So these are negative impressions, and then when you finally get the model, that is a positive reproduction. So when we're looking at dental materials, there is something called the preliminary impression. A preliminary impression are basically accurate reproductions of the patient's mouth. So this is the actual imprint of the patient's mouth, and they're used to make study models. If you want to document, the dental arc as part of your permanent record, you could use the study model to do that. And it's a great way to make a study model for patients' education so that the patient knows what their mouth looks like, and then you can teach them how to properly brush and floss using the study model. Final impressions, these are used to make cast and dies, and later I'll show you a picture of what cast and dies look like, but here you're getting exact detail. So this is a final impression is when you have exact detail of the tooth structures and its surrounding tissues. So you can get cast and dies from these final impressions, and that's what they use to make crowns, or they could use that to make partial or full dentures, or even restorations, such as implants, the place that are on implants. And this, what you see here, is a bite registration, and this is used to record how the max and mand, what their occlusal relationships are between the two arcs. So bite registration is good when you want to figure out what the articulation is, what the bite looks like of the max and mand cast. Here we see whitening trays, so these are things that can be made. This is a good example of a custom-made oral appliances because this is a custom fit to the client's mouth. Now when we're looking at impression trays, there's so many different types. There's metal, there's perforated, which means they have holes, there's plastic, there's even quadrant trays, which only cover half an arc. So there's even disposable ones as well. Disposable styrofoam ones. So lots of different types of impression trays that come in different sizes, small, medium, and large for children and for adults. So here is another question for you. The impression tray that is most widely used in dentistry for preliminary impressions is reversible hydrocolloid, irreversible hydrocolloid, addition silicone, or condensation silicone. The answer is B, irreversible hydrocolloid. And what does that mean? Irreversible means that once the alginate has set, you can't get it back to a liquid setting. Once it's set, it's set. So there are reversible hydrocolloids that are out there, and there's also irreversible hydrocolloids. So what irreversible hydrocolloid is, it's basically alginate. That's a good example of alginate, and it's irreversible because you can't get it back to its liquid state. But reversible, and there are some reversible, like agar. And what happens is if you take this impression with thermal factor, so with heat, you may be able to get it back to its original state. But the one we use in dentistry is the irreversible one, the alginate. They do not change their physical state after it becomes solid. Alginate impression material powder should be stored A, in the freezer, B, in a cool refrigerated place, C, in a cool non-refrigerated place, or D, at room temperature. The answer is C, in a cool non-refrigerated place. The reason for this is because the powder actually deteriorates. The quality isn't as good when it's exposed to elevated temperatures, so when it's exposed to something hot, or even when it's exposed to water. It's really important to store the powder in a tightly closed container in a cool non-refrigerated place so that the powder doesn't get deteriorated. So when you put it in a cold place, like a refrigerator place, it can deteriorate. And same thing with the freezer. And at room temperature, if it gets too hot, it could also deteriorate. So the best thing is cool, non-refrigerated place. Now, when you take an impression, it is really important to wrap it in a slightly moistened paper towel. And then you place it in a plastic biohazard bag. And the reason for this is because if you do not wrap it, you can get an uptake of water. So if there's like moisture around the area when you haven't wrapped the impression, you can get something called imbibition, which is where the alginate can expand. And now you're not going to get a true fit. The impression that came out of the mouth, once it expands, it's not going to be a proper replication of the client's exact mouth. And syneresis is when you get loss of water. So if the impression is left exposed and is uncovered, it can shrink. So again, it's really important that when you have your impression, you disinfect it, you wrap it in a slightly moistened towel, and you place it in a bag, because that is the way you can get the least amount of distortion. Otherwise, you're going to get it to either shrink or expand. So it's really important that you follow those steps. If you leave it exposed to the room environment and is uncovered, the impression can shrink, right? And that's what syneresis is. So how many scoops of powder are generally required for a maxillary, so the top maxillary alginate impression? 1, 2, 3, or 4? How many scoops of powder? Yeah, if you said 3, you are correct. 3 scoops of powder are needed for a maxillary alginate impression. The way I remember it is maxillary molars have 3 roots. Max, M-A-X, is made up of 3 letters, so 3 scoops for max. And so it actually needs 3 scoops of this and also 3 lines of water. Okay, so 3 lines of water and 3 scoops. So it's a 1-to-1 ratio. Now, when you're taking the powder, or when you're using the powder, be sure to fluff the canister, so turn it upside down several times before measuring with the scoop. With mandibular, so at the bottom alginate, you need 2 scoops of powder and 2 lines of water. So 2 lines of water, 2 scoops of powder. And unless someone has a large mandible, then you might need 3, but otherwise it's 2. And as we said, maxillary is 3 scoops of powder and 3 measure lines of water. Now, when you're mixing the alginate, that time that you have to mix is known as your working time, the time that's needed to mix the impression material, the time that's also needed to load your impression tray and to put it inside or seat it inside your patient's mouth. So that's known as your working time. The setting time is how much time it needs for the impression to set. So we have 2 types of powders. We have regular set powder and fast set powder, and you could have used either or in clinic. The regular set powder, if you look at the working time, you have 2 minutes. So you have full 2 minutes to mix the impression, load the tray, and seat it inside the person's mouth. So you have 2 minutes. And then when you put it inside the client's mouth, for it to set, it can take anywhere. It can take up to 4.5 minutes for it to set. So it does take a while for it to set. But a fast set powder, it just takes 1 to 2 minutes for it to set. So if you have a gagger, for example, the fast set powder might be great because it doesn't stay in their mouth for too long. Regular set powder can take 4.5 minutes to set. Fast set powder takes 1 to 2 minutes to set. And remember, loading the tray and inserting it, it shouldn't take you long. It should only take no more than 1 minute. If it's taking long, practice some more until you get the hang of it, because that actual loading of the tray and insertion into the mouth should take no more than 1 minute. There are even color changing alginates that are out there, which is really cool. So color changing alginate in which color when set? Is it white? So when it's set, when it's hard, when the impression material has become hard, does it turn white? Does it turn pink? Does it turn red? Or does it turn purple? If you said white, you are correct. It does turn white. So when the alginate powder mixes with water, okay, so let's just look at all the different colors. When the alginate powder mixes with water, it becomes purple. And then as you're mixing, once it turns into pink, that means, okay, it's now time to load the tray. So when it changes pink, you have to load the tray, and then you put it inside the person's mouth, and then it'll turn white. And at white, the white color means that it's now ready for you to take it out. It has now set. Red is not a color we see with color changing alginate. There are even some silicone alginate-alternative materials, and these are really cool. They're expensive, really expensive, 6 to 8 times more expensive than your regular alginate products. But the advantage of this is that you can pour and re-pour the models for weeks. So for example, I take an impression on you, I take it out, and I go to the lab and I pour up my model. And let's say I want to pour it up again. Maybe next week I want to use the same impression and pour up again. I can do so. If I want to pour it up 4 weeks later, I could even do that. So I have the advantage of pouring and re-pouring the models, the original impression tray, at any time after disinfection to up to weeks later. So it comes with it's convenient, it's flexible. It even has a mixing syringe, but they come with the price because they are 6 to 8 times more expensive than the traditional alginate products. When you load the impression tray into your client's mouth, make sure you tell them a few things before. Before you load that, tell them that the material is going to feel a little cool, but it will gel quickly. Tell them if there's going to be a flavor when you put it in their mouth, and you can check the canister, and that should tell you where the alginate powder is. Make sure you tell them to breathe through their nose, because that will help them relax. Tell them not to talk. If they need to talk, they can raise their hand. And when you load this in, we always load we seat it anteriorly and then posteriorly. We don't say it posteriorly to anteriorly, because if you do, everything's going to go all the way back. So seat it anteriorly and then posteriorly. The very important thing that I always tell my clients is to put their chin down, because when you put their chin down, all the alginate will pull forward as opposed to going back there, back in their throat. So once you've put this tray in, get them immediately to tilt their chin down so that all the alginate can come forward and not down their throat. What is the best method to control the setting time of alginate impression material? Should we add more alginate powder to the mix? Should we add more water to the mix? Should we change the water temperature? Or should we mix for a longer time than recommended? How can we best control the setting time of alginate impression material? If you said C, change the water temperature, you are correct. So when you change the water temperature, you can actually manipulate the setting time. For example, if you use cold water, you now have more time to mix. So it increases the working time. It also increases the setting time. If you use warm water, you will now have less time to mix because it's going to set faster with warm water. So you always want to use room temperature water. But if you feel like you need more time to mix and more time for it to set, then you can use the cold water. So warm water decreases the working time and setting time, whereas cold water increases the working time and setting time. So colder the water, the more longer it will take to set. The warmer the water, the faster it will set. The impression of a mandibular teeth should be taken first or second, because gagging is more or less likely in the mandibular area and enhances trust in the clinician for the maxillary impression. So what do you think? The impression of a mandibular teeth should be taken first. So always do the mandibular impression first because gagging is less likely in the mandibular area. So you're not scaring them. You're starting with an easy area. You're starting with the mandible because it's easy, because they won't gag. If you start with the maxillary, they're going to be gagging, and by the time you get to the mandibular, they're already traumatized. So you don't want to scare them. Always start with the mandibular, then do the maxillary impression. When you take the impression out, rinse it with water, okay? Because when you rinse it, you're removing saliva, you're removing blood, you could be removing debris. Shake excess water from the impression, and then there is a disinfectant spray that you can use to disinfect before you pour the gypsum into the mold. So this is what a bite registration looks like. It records the relationship of centric occlusion. Centric occlusion refers to the maximum stable contact between the max and the mand arches. So when the jaws are closed, it reaches centric occlusion. That's what it would look like. And so once the client has left the office, at least you know what it looks like when they bite down. So when you pour up your models and you make your study model or your cast, for example, you now know what it looks like when they bite down. Because of this, because you took the bite registration. Now this is a die, and a die looks like it's a replica of a prepared tooth basically, and it's constructed from a very dense gypsum product. And this is a working cast, which is like a stone that's strong enough for fabrication of indirect restorations or even prostheses, which I will talk about what that means in a bit. But this is like a working cast. This is a die, which is just like a replica of one prepared tooth, whereas this is a working cast. And so gypsum products, when you pour it up, you're using gypsum products. You could be pouring it up with model plaster, and that's like a study model. This is what we use, the plaster stone. You could be using a dental stone, which is a little more stronger, and then you could be using the high strength stone, which you need for cast and dies for crowns, bridges, and indirect restorations. Indirect restorations are a restoration that's made in a lab. So a crown or bridge would be made in a lab. Direct restorations are, and I'll get to that slide, but direct restorations are things you can do right then and there where you don't need to send anything to a lab. So like amalgam fillings, composite fillings, those are direct restorations. Indirect, crowns, bridges, where you probably need to send them to a lab, and you would use high strength gypsum product, high strength stone. So what are things we can do with custom-made removable oral appliances? Well, when you take those impressions, you could make a fluoride tray, you could make a tooth whitening tray, you can make a mouth guard, and then other things that are done in the lab are orthodontic alignments. You can make retainers, you could the lab could make sleep apnea appliances as well. So many things can be done from taking an impression. And they're all listed here. There's something here called parafunctional occlusal forces. Let's just review this term. Parafunctional occlusal forces, well, actually the opposite of parafunctional occlusal forces is functional occlusal forces. Functional occlusal forces is when you just chew. So forces when you're biting down due to chewing. But parafunctional occlusal forces are any forces that could happen to your teeth that have nothing to do with chewing. So for example, grinding, clenching, those are considered parafunctional occlusal forces because they are not related to chewing. So night guards, sleep guards, those are great examples of parafunctional occlusal forces because they help with grinding and clenching. So grinding and clenching are examples of parafunctional occlusal forces. And when you use these appliances, they can help reduce the clenching and grinding. And then they can also minimize the loss of tooth structures because when you crunch or grind, you can damage your tooth structures. And they also help with TMJ. These are periodontal splints. So when someone has a lot of bone loss and recession and their teeth could be getting wobbly, this splint could be put in to stabilize the mobile teeth, to stabilize the loose teeth and keep the teeth there for a longer period of time. All right, here's another question. How often should a removable oral appliance be cleaned? Daily, weekly, monthly, at regular visits? So think about like dentures, think about ortho appliances, the ones that are removable. How often? Daily would be correct. Yes, daily is the answer, because well, actually, we'll look at why in a bit, but one of the main reasons why you want to remove it daily is because you need to clean it. And so you need to clean it with a soft or extra soft bristle toothbrush and water. And if there is a removable appliance approved cleaner, you want to put it into that approved cleaner so that it cleans out. So, but you're also manually cleaning it with a soft or extra soft toothbrush. So this is an example of a retainer. And you can clean it with soft or extra soft bristle toothbrush and water, or you can even clean it with an approved cleaner. Okay, let's look at restorative now. Composites are being placed in preference to amalgams in large part due to what? Due to patients' demands for aesthetics, due to easier placement with amalgams, due to greater longevity than amalgams, or due to fewer incidences of recurrent caries. Why are composites placed more than amalgams? Aesthetics. If you said A, aesthetics, you would be correct, because aesthetics are so important. It's so important for clients these days. I mean, everyone wants to look better, right? Everyone wants to look presentable, look good. So composites are preferred for patients because of aesthetic reasons. Amalgam is good because it is actually the longest lasting material. It's not, technique sensitive. It's really easy to do, and it's the most resistant to recurrent decay. Recurrent decay means once you have a cavity, if you get a cavity again, that's recurrent decay, where you get a cavity again in the same spot or around the filling. So amalgams are great. However, composites are better because patients want them for aesthetics reasons. So why do people need restorations? What is the rationale for restorative therapy? I'm sure you guys know this, but to sum it up really quickly, if you have a damaged tooth structure, so if you have a chipped tooth, for example, you're going to need a restoration. If you have a defective restoration, so perhaps you got fillings done, but they were too big, they stick out, that's considered an overhang. Or they're too short, they don't fill up the entire area, that is considered submarginal. Or there's a gap, there's a margin, an open margin gap. It needs to be fixed because otherwise bacteria, plaque will get in there and it will start to rot or create a cavity, right, which we don't want. So if you have a defective restoration, such as these examples here, you'll need restorative therapy. You'll need to get it fixed. Sometimes if you have a missing tooth, if you have, cavities and it doesn't look good, people will come for restorative therapy for aesthetic appearance. It could also be for occlusion. So if you're not, when you bite down and it doesn't feel right, maybe you need some adjustment. Maybe you need selective reduction of enamel, because when you bite down, it doesn't feel normal. That is another reason why you would come for restorative therapy. And then there's also mastication. Mastication means chewing. So if you find that you have a missing tooth and you're not able to chew properly, if you have a defective restoration, so one of your restorations, something is wrong with that. Perhaps you're getting food stuck in the open margin. Perhaps there's an overhang and food is getting stuck in between the two teeth. With the overhang, and it's affecting your chewing, it's affecting your mastication, you'll need restorative therapy. And of course, if you have cavities and you can't bite properly, or you're only biting on one side because of cavities, you'll need restorative therapy. So lots of reasons why people need restorations. And when you look at types of restorations, there's direct restorations, and these are the ones that are done directly inside the person's mouth. You don't need to go to a lab. So amalgam, composite, glass ionomer, direct gold, where you don't need to go to a lab. But indirect is where you do go to a lab. So you take an impression and you send it to the lab so that they can make something in the lab, such as porcelain, crowns, inlays. And I have a chart from Darby. So this is from Darby, direct restorations. These are all examples of direct restorations. I do encourage you to pause this video and look at the advantages and disadvantages. So as we said about amalgam, it lasts a very long time and it's cheap and it's easy to do, but no one likes the color. So the patient acceptance is poor. Composite, is good because of aesthetics. Patients love it because it's white. But it does take some, it's technique sensitive. So you need to make sure it needs isolation, no water, no saliva should be in that area. Resin-Modified glass ionomer material is primarily used for class 5 fillings, which is just right here along the cervical. And you can see here what's nice about glass ionomer is it releases fluoride. So if someone's high risk for caries, this would be great because fluoride ions are being released, and we know fluoride helps with cavities. It's really easy to do. The only thing is it does wear away quite fast. We have the stainless steel crowns, which is good, but people don't like it because of its aesthetics. It's silver, it's not white. And it's also temporary. For permanent teeth, you can use it for primary teeth, but for permanent teeth, it's temporary. Then we have preformed zirconium crowns. They look like this. It's expensive, but it looks nice. When you look at indirect restorations, these are ones that you go to the lab to make, so a gold alloy, a porcelain, even porcelain fused to metal where they have that metal component. And then there are even CAD/CAM restorations where they scan your teeth and then they make it right then and there with a machine. It's like they can make an inlay or an onlay. So this is what an inlay looks like. It's inside the crown. This is what an onlay looks like. It's on top of the crown. You have the crown of the tooth, and this is an entire crown. So lots of things that could be made outside the client's mouth. The crowns primarily used for pediatrics, so children, are made of stainless steel, porcelain, gold, or tin. Stainless steel is correct. Stainless steels are cost effective, so it's cheap, it lasts long, and it does the job to restore primary teeth, especially when extensive, when you have lots of decay, big decay. So this is a great option. Tin crowns are not strong enough to last. Gold and porcelain crowns are too expensive, especially for kids. So stainless steel is your number one option. Okay, let's talk about dental isolation. I think I might have a question about that. Okay, no, let's talk about dental isolation. So dental isolation are dams, dental dams, and they're great because what they do is they help with moisture control. It's really important for most fillings to have a dry area, right? Essential dryness is extremely important. And so some restorative materials, when it's exposed to saliva or any moisture, it can really, it can fail. The restoration can fail. So the dental dam helps with that. Which of the following classification of restorations requires a matrix to be used? So they're all listed here. So class 6, class 1, class 5, or class 3. Class 3 is the answer. Let's look at why. So when you look at, so actually for matrix, which is this one over here, it looks like this. It is the key for a quality restoration, especially when you're doing any interproximal reconstruction or contouring of the interproximal tooth anatomy. So if you look at the classifications that are out there, they're all listed over here. You can tell that class 2 has interproximal, contains interproximal areas. Class 3 also contains interproximal areas, and same with class 4. It does kind of include the interproximal area. So anytime you're doing any interproximal restorations, you need a matrix system. You need a matrix band. And this prevents overhang so that the material can stay confined in that area and it won't hang out. So it prevents overhangs. Really important. And this is a wedge, and a wedge is good because what wedges do is they're triangular, they fit into an interproximal space, and they support that matrix band that we were looking at without encroaching on the contact area. So the wedge is really good. It gives it more support. Bases and liner materials aid in which of the following? Insulation under the restoration, work as a bonding agent under restorations, can lead to expansion of the restorations, or are bacteriostatic. Bases and liner materials. It is A, insulation. So what bases do is they preserve and they protect the dental pulp. So actually bases and liners, what they do is they insulate the pulp from temperature, so from anything hot, from anything cold. Instead, it won't hurt you because they put bases or liners. And I'll show you a picture of that. Just to look at the other options, they do not bond the restoration. They don't glue it together. They do not cause expansion, and they are not bacteriostatic either. They don't help with stopping bacteria. What they do is they insulate or they protect the pulp. So this is what a base looks like. So before you put in a restoration, you can put a base. You can also put a liner. And there are, so when you look at the product, it could be cement-based materials or it could be glass ionomer cements. And again, these glass ionomer are great because they release fluoride. And we know that anyone who has high risk for caries, we kind of like the glass ionomer because it has that feature, the fluoride releasing feature. So when you choose a material, it's important that it's strong enough to resist occlusal forces. So if you're grinding or clenching a lot, you want to make sure that it's a strong material so that it won't get damaged. And you want it to protect thermal insulation, so you want the pulp to be protected from heat. And if you're putting an amalgam restoration, and you want it to resist firm condensation. This is a liner, which is right here. And there are many different types of liners as well. And as we mentioned, liners are good because what they do is they protect the pulp. So there's glass ionomer liners, and that is the material of choice today because it releases fluoride. We used to use a lot of calcium hydroxide liner. It was commonly used before, but now it has been replaced with glass ionomer liners. It's a very thin coating that you put to the very internal portion of the cavity preparation. If you're around if you're doing a dental amalgam restoration, so if you're assisting the dentist, for example, or if you're an RRDH, a restorative registered dental hygienist, one thing to note is that just be mindful of mercury's toxic potential. It has come a long way. We're using careful handling now. We're using pre-encapsulated amalgam. So the pre-encapsulated amalgam, because it's safe, it just makes it less toxic. So amalgam, be mindful because it has mercury and it could be toxic, but we have come a long way in our decades of use because we are now carefully handling it, and we're using pre-encapsulated amalgam. Composites, like this, are tooth-colored restorative material, and they have resin matrix and filler particles. So it could be macro-filled, which is big filler particles. It could be micro-filled, which is tiny filler particles. Or it could be hybrid, where you have a mix of macro and micro-filled particles. So they have different categories of composite restorations. You do need a curing light for it to set. And they are incompatible with moisture. So you need a dry area when you use a composite, when you place a composite. Resin-Modified glass ionomer. This is another type of restoration that could be used. It could be a cavity liner or a restoration. The downside is that when it's exposed to saliva, it can dissolve. So now they have come up with a modified glass ionomer, hence the word modified, where they have compensated for the tendency to dissolve, and they've actually improved the restorative material. So glass ionomers have been modified. It's better now. It doesn't dissolve when exposed to saliva. And one of the excellent things about glass ionomer is that it releases fluoride ions. It has great aesthetics. And the modified one, the resin modified one, is even stronger than the regular glass ionomer. So if you have a root cavity, root caries, if you have class 5 abrasion, Class 5, as you know, I'm going to show you a picture so we can review our classifications, our block classification. Class 5 is right here in the cervical, so glass ionomer would be great for those type of fillings. It's also good for any class 1, 2, 3, and 4 restorations in primary teeth as well. When you place amalgam restorations, it's important to finish and polish these amalgam restorations, because what you do when you finish the restoration, you're producing the final shape and contour of a restoration. That's what finishing means, producing the final shape and contour of a restoration. Polishing is when you polish it, when you make it a shiny surface so that it doesn't, you can reduce scratches. Okay, so polishing refers to abrading the surface to reduce scratches to make a shiny surface. So you're making it shiny and you're reducing any scratches. We can also finish and polish composite restorations, which all these different burrs that you see. So there's burrs, finishing strips, and disc. There's points, there's cusp, there's like brushes, lots of things you can use to finish the composite restoration. There are even gingival retraction cord, which is either 1 or 2 strands that is placed into the sulcus. And what it does is it pushes the gingival margins away from the restorative prep. So when you want to prep the tooth, it pushes it away. And if you wanted to, when you take an impression, when you put that retraction cord in, at least when you take an impression, you can capture the gingival margins as well. So that's what a gingival retraction cord is used for. It's placed into the gingival sulcus, so it pushes the gingival margins away from the restorative prep that you need to do. And even when you take an impression, it can capture the gingival margins of the prep. Zoe, so remember Zoe from dental materials. Zoe stands for zinc oxide and E stands for eugenol. And what you do is you take the zinc oxide powder and you take the eugenol liquid and you mix it with firm pressure until the material is thick and it's like a clay-like material, and you can roll it with your fingertips and you put it in areas where you put it in areas where there's a cavity, for example. It restores in intermediate size cavity. Really important that it is temporary or interim, which means that it's just like, let's say you have a client that has come in and the dentist is not available. You can put this in the area where this cavity is, because they have properties inside the zinc oxide that insulates the pulp, inside the Zoe, there's lots of properties that can protect the vital pulp against anything chemical or thermal injuries. So hot or cold will protect it. So it's a temporary measure. And they're good for inlays, they're good for onlays. This is Zoe. Okay, let's look at ortho now. So we're going to look at orthodontic care. And anytime someone has malocclusion, so malocclusion is abnormal alignment of teeth, they would benefit from ortho. So if they have psychosocial problems, that means, let's say they have problems because, their face doesn't look good, so poor facial aesthetics, or they're not able to pronounce or speak properly. That could all fall under psychosocial problems. Oral functional problems are like if they have difficulty with chewing, with swallowing, with speaking, that falls under there. If they have rotated teeth, of course, they're going to have more plaque buildup, more debris, more stain, and then that can contribute to periodontal disease. If let's say their front teeth, for example, are protruding outward, and if they fall, what's going to happen to the front teeth? It will break, right? So if they have protruding teeth, injury is very likely, and so they probably would benefit from ortho. And if they have any TMJ or TMD issues, ortho can fix their alignment and help with relaxing their TMJ issues. So each of the following is a health professional with whom an orthodontist may work interprofessionally to complete orthodontic care, except one. Which one is the exception that an orthodontist may not likely work with? Is it orofacial myologist? Is it a speech pathologist? Is it a periodontist? Is it an endodontist? Or is it an oral surgeon? The answer is D, endodontist. An orthodontist does not work with an endodontist for root canal therapy. So root canal therapy and ortho, they don't necessarily go hand in hand, but an orofacial myologist could work with an orthodontist. If there's any orofacial myofunctional disorders, so for example, if they can't breathe, so nasal breathing issues, if the tongue is not resting properly, if they can't swallow, these are all things that the ortho and the oral myofascial biologist can work together and help out that client. Speech pathologists and orthodontists may send a referral to a speech pathologist or vice versa, because if there's anything abnormal in the orofacial function and if there's any speaking problems, speech therapy may help. Periodontists and orthodontists would work with closely. Sometimes an orthodontist would want the client to go see a periodontist before they start treatment, because if they think that they have a lot of perio issues, lots of bone loss, lots of, the gums are not healthy, a periodontist would work with the orthodontist so that when they start ortho treatment, at least all the everything's stable, the oral health is maintained. It's really important that we have good oral hygiene when we're doing ortho. And an oral surgeon can also work with the orthodontist if they need any extractions of teeth, if wisdom teeth needs to be extracted, if any extraction of teeth might be needed, if someone has a crowded mouth and we need to extract teeth, oral surgeons can help with that. Here's another question. Each of the following is a medical history consideration for the orthodontic patient except one. Which is the exception? Anti-seizure medications, bisphosphonates, asthma, arthritis, or diabetes. Which is the exception? So the answer is D, arthritis. So let's look at all the options. We need to know an orthodontic patient. So an orthodontist would need to know about anti-seizure medications, because what do we know about anti-seizure medications? Well, we know that it can cause gingival overgrowth. So phenytoin is an anti-seizure medication and it can cause gingival overgrowth, which can negatively affect like the braces. Especially, so if you have overgrowth, gingival overgrowth, and then you have braces and you're not taking good care of your oral hygiene, just imagine the damage that can happen to your gums. The amount of overgrowth can expand, can grow bigger. So that is important for us to know when we're looking at an orthodontic patient. Bisphosphonates are also important because if you remember from pharm, bisphosphonates affect the bone. So it affects the osteoblast and osteoclast activity. So bisphosphonates and bone is important. So bone and ortho go hand in hand, because when you have ortho, your bone is being shifted and formed and reformed. Asthma is also important because with asthma, your clients are using a corticosteroid, or probably taking a corticosteroid. And when you take a corticosteroid, you can get candidiasis, you can get thrush, you can get decreased salivary flow, you can get increased calculus, you can get gingivitis, you can even, you're more prone for getting periodontal disease. So it's important to know when someone has asthma so that you can work with them to maintain their oral hygiene. Diabetes, if someone has uncontrolled or poorly controlled diabetes, they now are at studies show that they're at an increased chance of having periodontitis or getting any periodontal breakdown. So we need to work with them closely. But arthritis, we don't know of any relationship between arthritis and ortho patient. No studies have showed anything, but A, B, C, and E are things we need to keep in mind when we are working with an orthodontic patient.